Now the second round of rebuttal will start. The other members of the PGH team can do the rebuttal now. You are allowed a maximum of 3 minutes.
Thank you very much. This is Dr. Quintos of the PGH team. I would like just to add a few comments to rebut the previous comments by the Zamboanga team. The main issue in breast conservation is mainly of cosmesis. Now, this could be answered, as mentioned previously, as immediate reconstructive techniques, and which can be done in the same hospitalization or probably in this stage reconstruction. It is certainly not due to a return of function of the breast, as Higgins in 1994 reported that a return of lactation in breast conservation techniques was not seen in a great majority, or about 80% of these patients undergoing these breast conservation techniques. Certainly not for psychological peace of mind. Noguchi in 1994 in the Kanazawa University Hospital studied a large sample of more than 2,000 sample size, reported a psychologic morbidity which is similar to both groups, such as the case also in Morimoto in 1994, who even expressed that the fear of recurrence was not dissipated and was even higher in the group of breast conservation therapy. Goldberg and Scott in 1994 also failed to demonstrate any psychological advantage associated with breast conservation therapy. Gans in the US and Lasry in Europe also mentioned that breast conservation therapy, in fact, may require, the group in breast conservation therapy may in fact require more intensive psychological intervention rather than in those in that group undergoing mastectomy. This may be due to the fact that possibly those undergoing total mastectomy have already more or less accepted or have a greater peace of mind in that the tumor recurrence may be low. Now, one issue that has not been discussed is that for the cost. Capri and Maury studied a United States population in 1992 and came up with the conclusion that the cost for the patient undergoing breast conservation therapy versus a mastectomy was 40% greater than that in the group undergoing only simple mastectomy. Now, it was included that the implicit costs of radiotherapy and chemotherapy may have been included in the computation of the cost. Now, the fear of high rate of local recurrence is very real. The importance, as has been stressed previously by both groups, the importance is in the excision of the tumor with a wide margin of resection. It has been stressed by both groups that provided that there is a tumor-free margin, then the results would be the same. Now, Morimoto in 1994 reported that in lumpectomies with a 2 centimeter margin for tumors 2 centimeters and below, cancer residue is seen in as high as 30% of these patients. Considering that the Asian population of the Philippines is included in the Asian population, in which the patients have more or less a small breast, in a small breast, a safe breast conservation procedure may not be possible without providing also a less than perfect cosmetic result. So, if we try to do a safe breast conservation therapy in patients with small breasts, then we could also be coming up with a mutilating procedure for the patient. For exit cosmesis, this can be answered, as previously mentioned, by immediate reconstructive techniques or possibly also by delayed reconstructive techniques.
Thank you, Dr. Quintos. Now, the other members of the Zamboanga team can now do the rebuttal.
Dr. Sammy Cristobal will now do the rebuttal for Zamboanga City Medical Center. Good afternoon to everyone from Maynila. This is Sammy Cristobal survival rate. So why can we not do just breast conservative management procedure? And the advantage is not only cosmesis, but it's also the advantage of the patient is not psychologically affected. And second, there is no restriction of mobility of the upper extremity.
Thank you, Dr. Cristobal.